Charcot arthropathy can happen because of multiple reasons. The theory exists that it is either because of neurovascular theory or neurotraumatic theory. Neurovascular theory suggests that the nerve dysfunction causes increased blood supply to the area and causes this deformity. Neurotraumatic theory suggests that the deformity causes trauma and causes injury which increase the blood supply to the area and then cause progressive destruction. As the name indicates, it's an arthropathy and eventually can cause fractures and dislocations. The most common causes are diabetic neuropathy, spinal cord injury, spinal dysraphism, syringomyelia, myelomeningocele, and leprosy or chronic alcohol abuse. Depending on the stage, there can be cellulitis, redness, increased temperature, reduced range of motion, radiograph showing fragmentations, loss of bony architectures, and joint subluxation. How to differentiate a Charcot arthropathy from the septic infected joint? So when you see the patient would be almost similar picture like infective process, but when you elevate the limb, the Charcot arthropathy swelling will reduce, while the infective process would have continuation of the swelling. Number 2, the inflammatory markers would be raised in infective process while it may be normal in Charcot arthropathy. MRI will show a collection in case of sepsis while it will be negative in case of arthropathy. WBC labeled bone scan can be done, which will be positive in infection while negative in arthropathy, and bone biopsy is indicated in certain cases. For classification, there is the Einholz classification, which describes the stages of the disease. Stage 1 is when the foot is red, there is edema, there is swelling, it looks more like infective process, and there is inflammation. Stage 2 is when there is fragmentation, there is destruction. Stage 2 is when there is a deformity ceases to progress and the soft tissue swelling reduces and there is a coalescence of small fragments. And stage 3 is consolidation phase where the fragment has resolved and the foot is again cold on examination. It is all classified by position or location of the involvement, and that's by Brodsky classification. So Brodsky classification starts from the midfoot. Stage 1 is midfoot. Stage 2 is triple joint. Stage 3 is ankle joint, which can be divided into A ankle joint, B calcaneus, and stage 4 will be combination, and stage 5 is forefoot. Regarding the treatment of Charcot arthropathy, our aim is to, number 1, reduce pain, number 2, improve the deformity, number 3, ulcer healing, number 4, to have a plantigrade foot at the end of the course of Charcot arthropathy. Regarding the treatment, if in acute stage, surgery is contraindicated. In the inflammatory stage, we need to assess the foot, examine the foot, and if needed, we can if there is ulcer formation, we can do a total contact cast. Total contact cast is a cast which is used to avoid to transfer the load from the area of the ulcer to the other side. This helps to reduce the healing of the ulcer. These casts should be changed weekly. Have a close inspection and examination is done. The problem with this cast is that there is a chance of pistoning once the edema is resolving. The second option would be to have a Charcot restrained orthotic walker, CROW. These are indicated in the later stages once the swelling is improving. This helps to transfer the forces to a different area which is not involved to improve the healing and go through the phases of the arthropathy. Second option would be in stage 3. When there is a coalescence stage, we can do excision of bony fragments or exostosis. The fourth option is arthrodesis, which is to place the foot in a functional position. In that cases, it's a highly challenging surgery. As per the NICE guidelines, they do not indicate bisphosphonates treatment, but it has been used and utilized with good results. Regarding the surgical intervention, fusion is indicated more commonly than corrective procedures.